Hey everyone, welcome to NextGen MD with Dr. Lily Johnston. We're talking about endarterectomies. Did you know that your doctor can literally go into your artery and scrape out the plaque? Well, that is how we define the endarterectomy. Dr. Johnston, would you mind giving us the clinical details and then the patient-friendly translation for an endarterectomy?
Well, I think you stated it pretty well, Kim. We make an incision over top of the artery, and typically, if we're talking about P.A.D, then we're talking about the common femoral artery. So that's the groin area. And we'll make an incision. We'll get that artery exposed, meaning so we can see it. We can put a clamp above and below the area that has the plaque, the narrowing. And then it's kind of like shelling out an orange, when you get that really satisfying orange peel and you get that all like in one piece. The plaque kind of shells out like the inside pieces of the orange, and you leave that rind around the edge. And then almost always these days, we are going to put a patch on top of the artery so that we don't narrow it when we seal it back up and close it up. That's the easy way to describe the endarterectomy.
Okay, so let's start with the common femoral artery. It's in the bendy spot,
Yep.
or so, and that's the reason why I would imagine that the endarterectomy is still gold standard for the common femoral artery, is because it is the bendy spot and it's pretty easy to kink a stent in that area.
It's very easy to kink a stent in the area. The other couple of reasons that an open approach tends to be still the gold standard are, number one, we like to be able to get in and out of the femoral artery for other procedures, right? Your cardiologist wants to be able to get in and out of the femoral artery to access your heart arteries, or the other leg, for example. And if you have a small narrow-celled stent in there, and the stents that most people are using can accommodate some sheaths and wires and catheters, but most people are not very comfortable doing procedures through the little holes or the interstices, as we call them. If you think about a chain link fence, right, the openings and the links between areas in the stent. So that's done more often in Europe. It is possible, but most of us are not super familiar or comfortable with that. So if we do an open procedure, it's easier to get back in that artery if we have to access other parts of the body. The other thing is that the bifurcation, or the common femoral artery, divides into the superficial femoral artery, which continues down and provides sort of the main highway down to the rest of the leg, and the deep femoral artery, which supplies the rest of the thigh. There's almost always plaque and disease right at that bifurcation, and both the SFA, superficial femoral artery, and the deep femoral artery are very important. And if we can treat the disease in that bifurcation area, where we peel it out and preserve that bifurcation, that's really helpful for the patients and for their legs going forward. When we put a stent there, the stent doesn't have really a pair of pants configuration. So, you're pretty much just going to get right up to that bifurcation. But if you're stenting there, you may shove plaque down one side or both of that bifurcation. You may not be able, some people will stent the bifurcation as well, stent into the deep and the superficial femorals, but that's a pretty uncommon thing to be doing. And so, if there's disease there, the best way to treat that is like with your eyeballs and looking at it and kind of taking that apart and pulling it out. And then we can reconstruct that bifurcation surgically if we have to. But that preserves the deep femoral artery, which is great for those collaterals that we talk about when we walk, walk, walk. Those collaterals typically are coming off the deep femoral artery branches to go around areas that would be narrowed or blocked from the SFA. But also, we can give ourselves a runway in the SFA, meaning a little stump, even if the rest of it is blocked further down low. If we open up just the top portion of it, when we come back for endovascular procedures, now we have a place to start where we can actually kind of be knocking on that door a little more easily, rather than what we would call a flush occlusion, meaning we don't even know where the artery starts because the disease goes right up until that bifurcation. So if we open up the top portion of it, surgically open, scraping out that plaque, then we have this runway where we can actually then go down, put a stent in, atherectomy, whatever the treatment needs to be for that patient. We are now facilitating that next procedure.
And the common femoral artery is a pretty good size artery if you're talking about kind of a main source for the leg, right? Splitting off the deep
Absolutely.
femoral
Yeah.
and SFA. And so there's a difference between going in there and literally shelling out the orange and going in there with a wire and balloon and creating a narrow passage, you're going to see much more relief, I would imagine, by shelling out the orange.
Uh, Intuitively, that makes total sense to me. I don't know that we have data for that. I would say we still, at least in this country, reserve common femoral stenting for patients that we don't think are going to do well with an open operation. And femoral endarterectomy is pretty well tolerated. So you'd have to have either a super high risk of infection and immunosuppression or multiple redo operations in the groin or be very, very sick. Meaning risk for heart attack, stroke. You don't want general anesthesia for some reason to really consider common femoral stenting as your primary option to relieve blockage or obstruction.
I don't know anyone that would stent the common femoral. I don't think I've ever been in a procedure in all the places I've been in the world where they would actually stent it. In fact, I was at a hospital in Southern California, University Hospital, and the doctor said, if we can't stent an artery, we don't treat it. This was way back when, but the artery in question at the time was the common femoral. And he said, standard teaching protocols dictate that we just don't stent that artery because it's just going to go down, it's going to kink. But what I was referencing was just the narrowness of the channel when you're talking about a wire and balloon and in catheters going through. Does that compare to the channel that you create when you actually go in there and physically or manually scrape out the plaque in the common femoral?
I mean, you'll get a bigger channel if you have an endarterectomy. The question is it clinically relevant? And I
Making
don't
a
know.
difference.
I once had
Okay.
to debate this issue in my fellowship. Actually, they made us debate common femoral endarterectomy versus common femoral stenting, and they assigned me the stenting
Oh
argument in this
no.
debate. And I was like, well, this is the worst because I'm obviously going to lose. Like, we were a very open heavy program. I had never stented a common femoral artery in all of my training. I had never seen it done. So I was like, well, obviously I'm going to lose. I actually won that debate and I made a pretty compelling argument. And I will say that in Europe, it is more common. And the Supera stent, which you may have heard of or encountered, particularly for the popliteal artery, because it does well in bendy places, like the popliteal artery behind the knee, can be used in the common femoral. It has been used in trials with pretty good success. You can actually access through it to put a 6 French sheath if you have to go back through the artery. More is possible than we think. And the rate of groin complications, especially with the rates of diabetes that we have, are not trivial. So I will say that it's less forbidden than perhaps we currently teach and learn in the United States, but it's still not commonly done.
When we talk to a patient about any procedure, if they're going to have a procedure, we always make sure they ask the question, what is the contingency plan? What's the contingency plan with stenting the CFA versus the endarterectomy if they fail?
Yeah, I mean, the problem with, stenting failure is now you're talking about open, and which now it's more complicated than if you were open in the first place. You could probably try to salvage it endo too. I mean, you can go suck it out or try to lice it open or balloon it back open, but it's a problem. And so the failure mode is a fair point. And certainly if you have, disease that ends up down the bifurcation or something like that, it becomes more and more complicated. And,
You do
open
bring,
endarterectomy, the failure for that is almost never reocclusion. It's infection,
yeah.
which is a problem. And we do see that from time to time, at which point we are redoing the endarterectomy. And if we're, we may have to remove the patch or put a piece of vein over top instead of the pericardium or instead of the fabric. Sometimes you have to use a muscle flap to cover it. You may have prolonged wound healing with a wound vac, things like that. That's a big deal. And sometimes the artery is so diseased that you try to shell that, orange out of the orange peel and it doesn't come. The whole thing just falls apart. If that happens, you can replace the femoral artery with, a prosthetic piece of tubing, right, fabric or plastic, and just replace the femoral artery and do an interposition graft instead.
Yeah.
So that would be something, in the moment, and I would say that's the minority of cases, but it's also something I have done.
And what is the recovery for the endarterectomy? And any questions patients should ask their doctor that will help them in the recovery process. I know one thing is to not sit at a 90-degree angle for the first few days.
Yeah, which, most patients aren't going to want to do that anyway. They're going to be uncomfortable, right? It's not the most painful operation we do, but excuse me, my coworker's helping here. But it's usually for pretty robust patients. I would say it could be as little as one night in the hospital. Other folks will stay 2 to 3 days. Depends on what else is happening. It's sometimes the only thing we're doing, but often if we may also be doing a bypass or stenting or other types of procedures. And depending on how the patient does, could be a little bit of a longer stay in the hospital. And again, I just tell patients to take it easy. I don't actually give them restrictions about sitting. I just give them restrictions about the wound, right? No soaking for 2 weeks. And I typically like to leave what they call a negative pressure dressing on there, where it's like a Prevena or a VAC type of a thing, which has some suction to it that patients go home with. So there's instructions about that. And that's the biggest issue, is just watching for any signs of wound complications.
Okay, so which arteries are right for endarterectomy? I know I've seen the SFA. I don't know it. I was just asked the other day about the iliac. I've never seen an endart for an iliac, but you also, if we're getting out of peripheral artery disease, you also have the carotids.
Correct. So I would say that the two most common would be the common femoral, like we talked about already, and the carotid artery in the neck. And that's for narrowing that would potentially result in stroke. I've done focal endarterectomies of the popliteal artery to like make a bypass target look better. I've done focal endarterectomies of tibial arteries to help facilitate a bypass. And then in the aorta, where the kidney arteries and the arteries to the intestines come off, it is also possible to do a very focal aortic paravisceral endarterectomy, or a trapdoor endarterectomy. I think I did one of those or maybe two in training. It's pretty uncommon these days, but because it's a tough place in the body to treat with a stent or other types of procedures, that can be one way to manage a big, what we call like a coral reef plaque, this like very lacy but bulky calcium plaque that sits right around all of those very important arteries to other structures. I don't think that the iliacs are common. By the time you sort of get to the iliacs, there's not a huge advantage in doing the endarterectomy versus a bypass versus a bypass, really, if you're talking about open surgery.
Okay. And finally, just critical questions patients should ask their doctor prior to having an endarterectomy performed.
I think it's the standard questions for any open procedure, right? Are you, my surgeon, comfortable doing this operation? How often are you doing this? What should I expect in terms of number of days in the hospital? Do I have restrictions when I go home? How will I know if there's a problem when we're finished? And those are the big ones. I mean, I don't want to undersell the fact that it's open surgery, but I will say that it's among the more common and straightforward open procedures that we do. I mean, it's I think less intensive than a bypass and less fraught. But I would say, what are, like, why are we doing it? Because if you don't know, you should. What are the expectations? So I'm doing a procedure tomorrow for somebody who has limb-threatening ischemia, and he has terrible rest pain. And he's like, well, am I going to be able to walk without pain after we're done? And I said, well, I don't know, because I'm just fixing your iliacs tomorrow. I'm not actually fixing your SFA occlusions. The goal is to get you out of rest pain so you can sleep again and not lose your leg. The walking, that may still be an issue, and we're going to walk, and we're going to stop smoking, and we're going to do a bunch of other things before we tackle that. So in terms of expectations, I tried to manage that. Like, my goal is to get you out of rest pain and out of limb threat, but you may still have pain when you walk, and I'll work with you on that, but we're not at a place where we're ready to tackle that piece just yet.
And that's a really good point. And we always talk about a less is more approach. You can't go in there and go zero to hero, because then you're screwed when everything goes down. And the more you touch, the greater the chance that it's going to go down. More trauma, every one of these procedures, right? It's trauma to the vessel, and your body issues a healing response to this trauma. So you want to minimize that as much as possible and depend on your own natural bypasses to try and get you through.
Yeah, I mean, again, it's very case dependent, right? We talked about the fact that if you're doing a bypass and your inflow is not good, well, you actually do have to do more, right? You cannot hope that the inflow problem is not going to be that significant, right? So there are times when you do have to sort of do all the things to make sure that the
Yep.
bypass is going to work and that you have your inflow and you have your outflow. But an iliac stent will, his common femorals are open, his deep femorals are open. He should have plenty of outflow, and hopefully restoring inflow should be enough to get him out of rest pain. And then we can work on all the rest of that stuff. So again, um, there are times where we do have to do more, but I'm hoping that this is going to be the right approach for him, for this patient.
And it's definitely a situation by situation
Yeah.
case, right? Because if you literally have no plumbing below, turning on the faucet's not going to do you any good. I mean, we always ask people, tell people to ask, hey, you're fixing the faucet. What does the plumbing look like below? And what is the plan? For you, Dr. Johnston, you have a plan in this particular case that you discussed. Okay, we're going to open up the CFA or we're going to open up the iliac. Yes, you still have some occlusions or narrowing, further down. Let's get the critical limb threatening component out of the way, and let's start you on a walking regimen, because we need to get your body starting to work for you and building those natural bypasses. Because once I start the process of opening up these other arteries below, that's the revolving door. And it's not a matter of if it's going to go down, it's a matter of when. And you need those natural bypasses to get you through when they do go down, right?
Yep. Yep. Got to build those pipes down below so that that outflow has somewhere to go. And yeah, if we end up getting to a bypass, we have better chance of success.
Thanks so much, Dr. Johnson. Really appreciate it. Make sure you do subscribe to her channel at youtube.com/Lily Johnston, or the @ then Lily Johnston MD. She has a great channel, lots of great content. She's constantly updating. Also, you can subscribe to our channel at youtube.com/the @ the way to my heart.